Well, hello everybody. Welcome to today's Hopkins Hour online seminar um, about pain. So this is following up from our National Pain Week, which happened last week, and there was a whole lot of social media stuff that happened through Hopkins um, with that. And today we have a wonderful lineup, and I would like to extend a warm welcome to everyone who's joining us online, all Hopkins Centre members, partners, and collaborators. I see a lot of people I recognise out in the audience there. So um, I'm a bit sad that we're not in person, but that's that's the way that we can all access this. So I'd like to start by acknowledging the traditional owners of the land on which we meet virtually today. My work office is on the land of the Jagera and Turrbal people, and I would like to pay my respects to elders past, present, and emerging. And we encourage all attendees to research and connect with the traditional owners of the land on which they live and work. Um, so my name is Nick Aitcheson. I'm a rehabilitation and pain specialist. I've got a background in physiotherapy before doing medicine, and I'm the director of the Metro South Pain Rehabilitation Centre. We're the public pain rehabilitation centre for the south side of Brisbane, covering a catchment of about 1.5 million people. I also work with the Hopkins Centre Research Engagement Council, and I'm going to be hosting today's online seminar. So there are a couple of housekeeping items to address. So we're aware that internet connections vary. So if you experience technical difficulties, please feel free to put a question into the chat via the toolbar at the top of your screen, and one of our events team will do their best to assist you. If needed, you can leave the Teams event platform at any time and return to it without losing your place. You can turn captions on via Teams meetings settings and clicking on the three dots on your toolbar, and then selecting language and speech, and then live captions. Please use the chat function to ask questions at any time throughout the session. So as things pop into mind, you can put them into chat as questions. So from the top level Teams navigation bar, you can select chat, and this will open a panel in the right-hand side of your screen where you can type your question or discussion and into the type a message box. We're going to have time for questions at the end. So there'll probably be about 10 minutes or so at the end for questions. And we'll answer what questions time permits, but any question that we don't have time for, we'll share the responses after the session. So just giving you an outline of what's going to happen today. We have some wonderful presentations lined up. I'm going to give a brief recap of our resources that were released during the Pain Week social media campaign, and give you a link to that. So that'll start things off, and then we're going to hand on to Hannah Kennedy and Niamh Jensen, who are doing research into virtual reality and pain. So Hannah's an occupational therapist and clinician pain researcher with the Hopkins Centre, and she works in the Gold Coast Pain Management Centre. Niamh Jensen works with me at the Metro South Pain Rehab Centre, and she's a clinical psychologist. Then we're going to move on to a presentation from Kelly Walsh and Frith La Vin. So Kelly is one of our senior physiotherapists at the Metro South Pain Rehabilitation Centre, and she and Frith have been doing some research into the ways that people participating in our pain programs perceive those programs and what they get from them. So some really lovely insights to be shared there. And then hopefully at that stage we'll have about 10 minutes, I would guess, maybe 10 to 15 minutes. We will have time for questions and a brief panel discussion if needed. So remember to put your questions in the chat as we go. So I am just going to get into my presentation now. So we'll go through, these are our presenters, as we explained. I don't think I properly introduced Frith. So Frith's our researcher with lived experience with the Hopkins Centre and with Metro South, especially with the Pain Rehabilitation Centre. She's a source of wonderful insight. So thank you, Frith. So this is a little overview of what we did last week with Hopkins Centre. I would encourage you to use that QR code or take a photo of it or something like that so that you can link to the Hopkins Centre pain resources that were released on each of the 5 days. So I give you a little bit of time to do that. But you can also find them by Googling Hopkins Pain Week 2025. I found it a little bit tricky to find just going straight through the Hopkins Centre website, so it's easier to do a search for it. So what we did was, beginning last Monday, we released resources around one theme for each of the 5 weekdays. So on Monday we released these resources around understanding pain as protection. So basically how pain works to protect our bodies. And then on Tuesday, some resources around soothing that overprotective pain system. Wednesday, we looked at movement and how you can move with pain and how that can calm the pain system. And on Thursday, we looked at diet, sleep, and the natural world as ways to calm the immune and nervous system as well. And on Friday, we looked at some of the things that might help people with pain and other people link into their community more. So just as an example, this is from this is from Monday, understanding pain as protection. The Pain Revolution fact sheets are really great. So that's from the Pain Revolution fact sheets. Then on Tuesday, this is from Live Well with Pain, which is a really, really great website with heaps and heaps of resources. And then on Wednesday, we had movement and its role in calming the pain system. And this is from the International Association for the Study of Pain. So each day has probably 5 to 10 resource links to different resources and web pages, which are really useful. So you can explore through each day and look at things that you might find helpful for you, either in your role as a pain clinician or someone who lives with pain, or someone who has both. And I love this website. This is from Thursday. This is, I think it's called My Noise or something like that. It's it's a collection of very, very high quality recordings of soundscapes from around the world. So a lot of white noise generators are artificial noise. This is real noise that is recorded in very high quality. It's beautifully soothing, and you can choose a soundscape to match your mood. And I've included the Chronic Pain Australia website as one of the examples of the links that we shared on Friday. So Chronic Pain Australia is really useful as a launching point for connecting to other people with pain, and also pain clinical resources. So I'd encourage people to get involved with that. So I would like to say thank you to you guys for tuning in and have a look at those pain resources. But now I will hand over to Hannah. I think it's Hannah's turn now.
Thank you, Nick. And thank you for the introduction earlier. Myself and Niamh are really excited to present on behalf of the number of different teams across Queensland Health that have been involved in our virtual reality research. And we're really excited to share this as just one example of the innovation and research that is happening to support people's progress with pain management. So this afternoon we will be talking around the role of virtual reality for pain education and rehabilitation. So just a brief overview around virtual reality, quite commonly known in the gaming area. It's the use of a device or VR goggles that provides a really immersive and interactive 360-degree multisensory experience. And it has been used in a number of different areas in health already, with a really growing evidence base for the potential that it has to improve health outcomes. Quite commonly known is the use of VR for exposure therapy for conditions such as PTSD and anxiety, as well as in the area of acute pain, where virtual reality can provide really strong distraction tools to help with acute pain experiences. But you can see here how it's really being applied to a number of different health conditions, really to address both physical, cognitive, and emotional components for rehabilitation. When we look at how we can apply virtual reality in a clinical setting, there's a number of different ways it can be used. As mentioned before, the role it can play in exposure, where being in a virtual environment can replicate some settings that you couldn't access as easily in the real world, and can also assist providing some safety and constraints to the level of exposure that you're doing in the VR environment. It can be used as a tool to measure in terms of eye tracking, attention, cognition. Really commonly, people can understand how it can be used as a strong tool to support with distraction. And more interestingly, I think we find from a rehabilitation sense, it's got this potential to be quite a motivating tool when you think around the gamification that it can have to engage with both physical rehab as well as cognitive rehab activities. And finally, from an engagement point of view, it provides quite a fun and novel way to do many of the rehabilitation treatments that we're interested in. When thinking about the strengths of VR from a technical side of things, they talk about the 4 pillars of VR in terms of its offering this strong sense of presence, really being there in that virtual environment rather than being in the clinical treatment room. Immersion around really being engaged and caught up in that virtual world that you're involved with. Embodiment in terms of feeling like either the virtual hands or your virtual avatar is a part of your body, which offers a lot of exciting potentials from a neuroscience perspective in ways that this can be used for rehabilitation. And finally, its potential with being quite an interactive and having a lot of agency over what you're doing in the VR environment. So that level of influence has been shown when it's got a stronger level of agency and influence, then we see some greater potential outcomes from a rehab sense. But why or how are we using virtual reality for persistent pain? When we look at the evidence base around best practice pain management, we now know that when people develop a contemporary understanding of pain science, then improvements with rehab are more likely. So when we're talking about contemporary understanding of pain, we're talking about seeing pain as a biopsychosocial phenomenon. And like Nick mentioned just earlier, seeing pain as a protective system and how we can help to retrain our pain protection. So we know that having this modern understanding is really important for rehab, but our current didactic use of pain education has some limited effectiveness. And we see that around 50% of patients who are provided with pain education are having a shift in their understanding of pain, but that still leaves 50% of patients who aren't having a change in their understanding of pain despite these educational interventions. So we feel like there's a really critical need to develop better ways to teach people about pain. And so this is where VR comes in. So we have collaborated with an Australian software company called Reality Health for our research, and the Reality Health team had developed a VR immersive chronic pain education and rehab platform under the scientific advisor of Professor Lorimer Moseley. And what their platform does, it combines the key concepts of pain science education with the active learning principles of how to best educate and understand and have that conceptual change with the tech side of these immersive VR experiences. So you can see on this picture here, this is just one snap from the platform where there is a fire that appears in the VR platform, and you're encouraged to put your hands over the fire. And for many people, they actually feel warmth when they have their hands over the fire, which is a really fascinating sort of experience to have when you know you're in a clinic room, and how our sensory system can still be provoked even in a virtual sense. I'm going to hand over to Niamh to talk a little bit more about the platform and the protocol, but first the next slide will have a short little video about the taken from the platform. Is the sound coming through, Niamh? Leave me one moment, sorry.
Yeah, no, I can't hear the sound.
Let's do that bit once more.
Whoa, be careful looking down. You are standing on the edge of a cliff. Beautiful, but dangerous. If only we had something to keep us safe from falling. Let's move you back from the edge a bit. Pain is like a safety fence that keeps you from falling off a cliff. It keeps you out of the danger zone, protecting you from injury. Remember the fence on the cliff, and remember all the things to the right of the fence that you used to be able to do but can't do now.
And that's the end of that clip there, Niamh.
Yes. Cool. So this is just one of the other embodied metaphors used in the program. So without much warning, the participant is actually transported to the cliff edge, which is a bit of a surprise, and it usually provokes one of two responses. So either someone is not really good with heights and they get a bit of a shock that they're on the edge of a cliff and might feel, that anxiety within their body. They might get wobbly legs. Others who are kind of into heights might go, wow, that's super cool, and they get this sort of rush of excitement at being transported to the cliff. And so what we have happening in the VR space is this really real physical response to a dangerous or risky situation that it's not actually real, but our brain perceives it as real enough that it will produce this automatic sensory physical response to the sensory input. And this is one of the ways we can show rather than tell about how the pain system works, how we get these automatic safety responses from our nervous system when we're exposed to any kind of threat to that system. So the program uses some pain education modules, but then we also have some rehab modules. So these are different activities that involve very safe, gentle movements in different ways, and they involve a degree of gamification to sort of make them interesting. So the first one there, our lights game, is all about moving in different directions. Some of them are high, some of them are low, and the person has to touch each of the lights as quickly as they can before they disappear. So it sort of encourages, movement, bending, squatting, and over time we actually see some really nice change in the quality of people's movement as they do this activity multiple times. Their movement starts to get more fluid. It uses a bit of gamification to create like a reward system as well. So potentially we get some dopamine hits as well. So every light that people touch, they get a score. They can see the score increasing, and that in itself will create more reward to move and keep moving. The shapes activity in the middle is all about picking up and sorting different things according to different rules, and the rules change. So it's a little bit like the for those psychologists out there, the Wisconsin card sort. It's a little bit like that. They've got to figure out the rule based on the feedback that you get from the VR system in terms of whether you've got it right or whether you haven't. As the game kind of progresses, it involves increases in the amount of movement. So the plinth will decrease in height so that you actually have to bend a little bit further to get to the shapes to sort them for each subsequent game. So in this way, it sort of emulates a graded movement or graded exposure approach. So we're slowly getting people to move more and more, and we're having them problem solve at the same time as a way of like changing the context of that movement. And then finally, we've got kites, which is almost, you're sort of at the edge of a cliff, but you're flying a kite in the air and you've got to catch dots. So again, this one is gamified. It starts with sort of a baseline of calming environments, but we can actually amp up the level of danger in most of these games as well by changing the environment. So whether that is flying a kite right on the edge of the cliff as opposed to a little way back, or some of the others, we can arrange it so that the platform like moves high in the air so that you're sorting shapes, 30 feet high. And in that way, we can kind of change the context to make it a little bit more challenging, a bit more dangerous. And that kind of challenges the pain system a little bit more, and it challenges those movements under more threatening environments. And all throughout it, we have little snippets of pain education that help to reinforce the learning that's occurred through the first 3 modules as well. So nice little nuggets of information that are just sort of added in as people have rest breaks through the rehab activities. So what we're doing with our implementation study is looking at how we can use this program in our everyday work at our pain services. So excuse me, each of the public pain services in Queensland are involved. And so throughout the state, we're aiming to recruit a number of participants to try this out and track their outcomes. So each session goes for about an hour, and we have 6 sessions that we try to run on a weekly basis, but generally they'll spread over sort of up to a couple of months. And we're using the MetaQuest VR headsets, and they come with sort of little hand controllers too that we can use to do different things, or we can enable participants to actually have hands that work and do things in the virtual space. We're using the Reality Health chronic pain management VR platform, which the first 3 sessions involve these lovely, simple, evocative, embodied experiences that teach us about how the pain system works and are incredibly memorable for people, utilizing, you know, really strong visual and sensory responses to show how this works rather than just feeding people information. So a lot of the feedback I've had from people who've done it is that they walk away remembering a lot of these experiences and that they were really strong, and really kind of helped turn the corner in terms of how they were thinking about their pain. To sort of standardize this across all of the services, we're using a workbook to kind of guide our way through. So first 3 sessions are sort of heavy on the education side of things, with a bit of rehab thrown in, and then the final 3, it's a lot more rehab. We're looking at things like breathing exercises as well that are again done in the virtual space. We look at flare-up management, and all across the 6 sessions, we're focusing on helping people to look at some nice, simple goals they can start to build upon over the course of the project. So this is just a slide looking at all of the different health services that are involved. We will, I think, have the paediatric service joining us shortly as well. They're going to start using it with some of their patients. So we're aiming to recruit about 150 people to try out the pilot within our clinics as a part of their usual care. The aim is to get at least 25 different clinicians involved, and it's a really interdisciplinary approach. So any of the clinicians really can be involved in delivering the program after having some training and feeling, you know, familiar and confident with the way the system works, getting around, you know, navigating the headsets and getting a feel for how the program goes. So I think we've had 30 headsets arrive. I think there's still more to come. And we started off, I think Hannah started early in sort of mid-2024. We're aiming to finish this by June 2026. And we've been lucky enough to have some really good funding through the Queensland Technology Futures Fund. So what we're aiming to do is sort of evaluate this using the RE-AIM implementation framework, which is a way of looking at effective research translation into clinical environments. So we're aiming to make sure we're reaching the population that we want to reach. We're looking at effectiveness or efficacy of the intervention in terms of the outcomes we'd hope to see. So we want to hopefully see changes in some of our clinic questionnaires. We're looking at, you know, is it being adopted by the staff that we're interested in encouraging to use it? Does it work within the public pain service setting? We're looking at implementation consistency across the sites, costs, and any adaptations that might need to be made to use this in daily pain care. And then looking at the maintenance or sustainability of the effects of the intervention over time. So we'll be tracking people pre, post, and at a 3-month follow-up after they've completed the program.
Thanks, Niamh.
No worries.
Just to, I suppose, summarise and give an indication of where we feel the utility of this intervention is coming in. So we first completed this VR intervention at the Gold Coast Interdisciplinary Persistent Pain Centre as an RCT in 2023 and 2024. And this is just a snapshot of some of our results, which are in preparation for publication. So we saw a high acceptability from the patients who got to do this VR intervention. So when we're looking at their satisfaction with how easy the headset and the technology was to use, how much they enjoyed using the VR headset, whether it helped with their pain coping, and a high desire to use the intervention again or to continue using a virtual reality. The other nice little snapshot is the global impression of change. So we asked patients at the end of their 6 sessions, compared to before they started, has there been an improvement in these 4 areas? So we had 80% of our participants report there'd been an improvement overall. 80% of participants reported an improvement with their physical activities. We had an 84% report an improvement with their mood, and a 68% participant report an improvement in their pain. And with this RCT, we had 83 participants recruited to the study and were randomly allocated one of 3 interventions. So this is looking at 28 participants who did the VR intervention that Niamh's described. Just one short quote from a participant. We did semi-structured interviews also with people at the end of the 6 sessions. So this person here said, I had no idea how pain actually happens in the body. The very first moment of the very first lesson of learning that it's my brain that makes pain and not my body. That was a real revelation moment. There was a real light bulb. And so from the qualitative interviews, there were sort of 5 key themes that were generated looking around the acceptability, utility, tolerability, where we found that people thought it was a fun way to learn and recommended for other people with pain, that the more they learnt about pain, it changed their pain management in terms of what they did, how they coped and their function. From a tolerance point of view, people reported that it was just right for them in terms of the weight of the headset, how long they were wearing it, being able to get to 6 sessions. And interestingly, 2 other themes were that having a clinician alongside them to deliver the program was really important to help them feel safe, but also to help understand the information and apply it to their situation. And that the learning environment was a really engaging way to learn about pain science. So to conclude, we're really proud, I think, and excited that this is the first public health delivery of using VR in this way for pain education. And we're doing this as a statewide collaborative across the pain services. And we see it as it's a high value use of health resources. So the VR program is designed to enhance that health literacy for long-term health management. And it's our vision that this will become a part of usual care in pain management. And we're really excited to be supporting Queensland Health in terms of adopting new technologies that can help improve the outcomes for people with pain. Just a note on future areas we would love to progress this to is improving access to people who can't get to a tertiary pain management service. So looking at a model to support the rural and regional delivery of a VR intervention, and also expanding to many of the other areas of healthcare that are impacted by persistent pain. Thank you very much, and I will end my slides and hand over to Kelly and Frith.
Great. Thank you, Hannah. Hi, everybody. My name's Kelly and I'm joined by Frith here. We're going to talk to you about our research project, Making Interdisciplinary Pain Management Programs More Patient-Centred, a qualitative study of patient perceptions of the engaged pain group. Very importantly, I'd like to recognise that this is very much a team effort going into this research project as well, and there's our team there. So just a brief background, interdisciplinary pain management programs, or IPMPs, are the gold standard practice for helping people with persistent pain. There's a range in regards to the group format, the intensity of them. They all have sort of similar concepts in regards to pain science education, having psychological intervention, and looking at education and skills development to help with people with persistent pain. Where this came from was that we do run a low intensity IPMP here at the MSPRC, and it's called our Engaged Group. So the way that works, it's a 6-week group. So participants come for a 2-hour session once a week over 5 weeks, and that's run jointly by physio and psychology, and one session is psychology and OT. And then in week 6, they're given a follow-up phone call sort of for some treatment planning from there. Importantly, here at MSPRC, it is not the come and do this and see you later. It's part of a patient's journey. So really we use that to form a foundation to the where to and how do we progress you in your pain rehabilitation. But what we were seeing is that when we were taking on people for treatment after doing Engage, is often we were reteaching concepts that we'd already taught in the Engaged group. And that really led to this sort of question about, well, what are people actually learning, given that we are teaching to the pain science concepts and the key understandings, and we're incorporating, so we use ACT-based clinic. What are people taking from this group? So it led us down the path of a scoping review where we found that there's sort of evidence out there for the efficacy, the patient experiences and satisfaction with IPMPs, but there was a lack of evidence in regards, well, what are people learning? So our research aims are based upon this, and essentially they're what did you learn and what's different? So how have your beliefs and behaviours changed as part of doing this program? And we're using that to drive our secondary aim, which is how do we develop, which is developing recommendations on how to improve IPMPs, so to person-centre them from the participants' perspectives. It's a two-phase research project. I'm going to talk about phase one today, which is our reflexive thematic analysis, and that's going to inform our recommendations, which will form phase two. So just briefly, what we're doing is we're doing a pre-engage interview. So that's 1 to 2 weeks prior to participants coming to the engaged group. They're then attending a focus group, which is after each of the in-person sessions. So there's 5 focus groups in total. And then 4 to 6 weeks after completing the whole group, there's another phone interview. What we're exploring there is in the pre-interviews, well, what's your current understanding of pain, acknowledging that people have often had some pain education or they've sourced this on their own. How's pain impacting your day-to-day, and what are you still doing even though you've got pain? We're tracking that along the focus groups to see what are you learning from attending the engaged program. Are you doing things differently? Have behaviours changed? And other feedback in regards to the way that it's run. And then our post interview is reflecting that again. What's your current understanding of your pain? What are you doing differently? What things did you learn? So I'm going to talk to you about where we are in our reflexive thematic analysis, or RTA. We have completed all of our data collection. So we have 13 full data sets, and that's from 3 engaged groups. And we also have, I think, about 5 just initial interviews. And what we've done here is we've then mapped it with our RTA, and we've developed this overarching theme from our pre-interviews, which is it's a personal pain puzzle. So what we're really seeing is when people are coming in to engage, pain is like a puzzle. You know, they're trying to figure out what's causing my pain, why is it there, what can I do about it, how do I sort of ease it or cope better with it as well. And essentially what we see with that is a lot of grief and loss over the person people used to be, and also a reduction in activity. So we're seeing people's worlds are getting smaller and smaller, whether it be through reducing their general sort of physical activity or their social engagement as well. Underneath the overarching theme, we then have 3 themes, which I'll speak to. So our first theme is the change in self, and I've got a quote under each of the sub-themes here. So what we're seeing is that when people are coming in to engage, they're really describing this big sense of grief and loss about the person they used to be and where they were going in their life. And so that's our sub-theme, I'm not who I was or who I wanted to be. And this person's talking about how pain's taken away his whole life, not even who he was, but it's also his future self is then gone, and it's also affected his families. And that resonated across all of the interviews. The second sub-theme there is I'm not who I was, but I'm still someone. And so whilst there's a lot of this grief and loss that we're seeing, we're also seeing that people are then putting in other things that they can do in their time. So some other people have sort of upskilled in computer-based programming. This person has changed his life based on his pain, and that's fitted in better with his family. What's interesting in all that is mostly it's sedentary things that people are engaging in. So sort of physical capacity and active things have sort of taken a back seat, and also people still aren't really happy. There's still that sense of loss. I'm doing this, but it's still not great. And our third sub-theme there is we're not happy with the status quo. And this really came across from the focus groups where people are talking about one of the reasons they're attending Engage is they're not happy with where they are now. You know, and this chap's talking about his activity levels, that the status quo is dissatisfying. He wants to be back to where they were. And that was reflected with a number of other participants too. So that really gives us a good opportunity to kind of focus on what are IPMPs about? Is it about helping you with who you are now, your current self, or helping you to move into your self with pain? And how do we explore that with people in regards to their values and such? Our next theme there is putting the pieces together. So what we're seeing from these pre-interviews is that people are trying to figure all this out, and that starts with their personal pain theory. So people are coming in with an understanding of their pain. Whilst pain is a biopsychosocial phenomenon,
it is really a biological understanding that is dominant in these interviews. And this is despite people having seen multiple health professionals and many, having had their pain for, 20 plus years. So this person's describing how it's the degeneration of the spine and that the discs are pressing on the nerves, and that's what's causing the pain. Some people did recognize a psychological aspect to their pain in regards to how their mood might influence it, but usually that's then attributed to the mood is driving my muscles to become too tight, and then the tightness is causing my pain. There was no recognition of social factors in regards to the pain experience across our interviews. And again, this really helps us go, okay, this is where we kind of can step into our own of helping people broaden their understanding of the biopsychosocial pain experience. We've got figuring it out there as our next sub-theme, and people are really trying to work out their pain, what's causing it, aggravating, easing factors, and what can I do? People are doing this alone. So whilst they've seen many health professionals, it's really an isolating experience where they're having to pull bits from different people together themselves to figure out how do I best manage my pain. Lots of using internet resources, which again aren't always the best, and sort of describing that sometimes getting lost amongst that as well. And finally, we've got the sub-theme of the disconnect, which is when the pieces don't fit. So this is talking to how some people are coming in with this modern pain science understanding of their pain, and that's often through previous education they've had, whether it be through other IPMPs or other health professionals, but often it doesn't fit with how they're experiencing their pain. So this person's talking about how, yeah, I know pain is produced from the brain, but it's in my body. I feel it in my back and my neck. And that, again, was consistent across a couple of people, and to the point of where I know we're trying to learn it's different, but it's hard to understand there's nothing wrong when I feel my back is in this much pain. And so I think that really shows the importance of that de-threatening and really helping people understand how does the pain science relate to their own experience of pain as well. And finally, the theme of healthcare helps and healthcare hinders. Now, this is tracking across the focus groups. When people are coming into the Engage pain group, they have often had quite negative healthcare experiences. There's a lot of invalidation. People are not believing what they're going through. And again, they're figuring it out alone. So really those negative healthcare experiences are quite dominant, again, across the board here. The group then plays a really big role in affirming and validating people's experience living with persistent pain. So it's not just the pain is real, it's also all these things that you've done to help you manage your pain. These are legitimate and other people are doing them too. And that connectedness helps to reduce that feeling of isolation. And for some people, feeling like they're, what am I missing here? So the group process is really key in all of the changes that we're seeing, and I'll talk about a couple of them as well. And it's key in really reshaping people's relationship with themselves as well. We're finding that people with persistent pain really benefit from learning from their peers just as much, or if not more, than the health professionals. And again, that's really speaking to the recommendation with IPMPs of making sure that group, we're harnessing that group benefit, we're allowing for that discussion, letting peers lead it as well, because they learn off each other so well. The other thing is the peer-to-peer connection. People, they really get it. A person with persistent pain talking to another person with it, they really get it. Whereas talking to their loved one, they might try their best to understand it, but they don't actually experience it. And there's a big difference there as well. The group is playing a big role in social connections, reducing isolation, and also it's the focus groups, which were a new thing because they're part of this research study, are a really valuable learning tool. And that's something which we're going to harness here at the MSPRC. So these are just two quotes which speak to this group benefit. And this first person is talking about how, every week I had something to do. I had somewhere to go to. I put my makeup on and I had to go and I meet these people. And then I realized that what I'm lacking is that social interaction. And the next person is talking about they're learning from the peers in the focus group. He's sort of saying, this is the focus group is really crucial in this experience, and it's helped just as much as the lectures. We try to make it not didactic, but maybe that's not true. The lectures themselves, and that was again resonating. It's really helping me too. These are just as, if not more, valuable as well. So now I'm going to move to what are we seeing? How are we seeing this track across the focus group? So we've labelled this the shift, in which we're seeing some shifting in people's understanding of their pain, but also their relationship with their pain and themselves. So we've labelled this so far as reconceptualizing, reframing, and reshaping. So people's pain understanding is changing, their ways to manage pain, and sort of pulling in different strategies and how they might use, say, for example, a strategy for anxiety. How can we use that for pain? And understanding that in a more proactive way is really helping people to reshape their relationship with their pain. So rather than fighting it, hopefully walking with it, and also their relationship with themselves. So there's a lot more being kinder to themselves, being gentler, reduce feelings of guilt. We're seeing what we call movement talk, which is in the beginning, in the pre-interviews, people were really, really stuck. So when they were asked, what are you still doing even though you've got pain? It always went to the what I can't do. Whereas now with this movement talk, we're seeing that behaviors are changing. People are doing things differently. They're reintroducing things into their life. And this was occurring with people who even said that they're not learning anything from coming to the group. So whilst they're not learning anything, they're still changing the way they behave in a positive way. And then we've got approaching a life with pain differently. And so this is very small steps, but again, it's not the be all and end all coming to engage. It's the start, hopefully. So we're seeing people's lives are changing and the way that they're thinking of what do I need to add. And in fact, I had a lady today say, I recognize I need more joy in my life. And that's come from the group. So this is really exciting stuff for how do we move people forward after IPMPs. I've just got this nice quote which kind of encapsulates all of that. And this is a lady who's talking about how understanding pain more has led to a de-threatening process with her pain. So when she gets pain in her ankle, she's talking to herself saying, I'm safe, there's no danger, and that's then reducing that threat value and she's able to do more. And Frith, who always coins things so nicely, has coined the term walking with and talking to your pain. So in that reshaping, she's then able to do more, which is really, really lovely to see. So we are also seeing what we call these disconnections as well. That's something for us to work on, and I have no doubt that occurs in other IPMPs as well. So people's expectations of Engage versus what it actually offers. And again, we'll work on that. How some of the pain science concepts or other concepts are relating to their own experience. And I think we need to really work on how do we personalize this to each person and how can they try to conceptualize concepts for themselves, and how some things that are discussed might actually relate to pain. I've just listed a few other areas for person-centering IPMPs, which is really, I think that harnessing the group effect is really, really a big one there. Ensuring that validating and affirming healthcare experience, because for some people, this is the first time they've had that, and other things like learning styles and environmental considerations. Just very quickly, we're continuing to do our coding and then we'll lead into our phase 2, which is a co-design workshop. So I'm going to pass over to Frith now, who's going to talk about how this resonates with her experience.
Thank you.
Stop sharing. Oh, I
Yeah.
might leave it at.
That's all right. So as Nick said in his very kind introduction, I have lived experience of pain, but I also have the experience of having gone through the Engage program myself. And although I had a very positive and constructive experience, I did have some ideas at the end of some small things that would make the program more accessible and easier for people like me. That being said, when I came on board, I wasn't prepared for how much reading the excerpts from the participants would affect me. And one of the things we talk about in the study was the change of self and the loss of self. And something that's been part of that process for me is developing a neutral attitude to myself as someone with persistent pain, somebody who's not as productive as I used to be. And what this study has done for me is reading these excerpts. These are like funny, intelligent, empathetic. They're just brilliant people. And it's shocking to me. It's very sad to me to hear them all describing lives that are often completely detached from their communities. And that strikes me as a huge loss, not just for people living with pain, but to us as a society as a whole. And so I'm really hoping that through this process and through this research, clinicians will also experience that same reframing that I have in seeing the immense value of people who live with persistent pain. And for anyone who's watching today who is living with pain, and if you have the opportunity to participate in something like this, I strongly encourage you to take it, because it's our voices that will lead to better care. Yeah,
Thanks.
that's all right.
I'll pass it back to Nick.
Thank you so much, everyone. We've got one initial question come in for Hannah. And I guess we've got about 9 minutes left in our session. So do you want to address that question, Hannah? And then we might have a bit of a chat about reflections on the session, or if any other questions come in, we can answer them.
Sounds good. Thank you, Claire. That's an excellent question. For the VR initial study, the 3 interventions was the VR 6-session program, a home-based book education and workbook, and then a waitlist control. So we did compare against those 3 interventions. Obviously, they're not super comparable in terms of the tech and the time and the clinician involvement. And we haven't compared them against pain programs. A lot of the sentiment has been not seeing it as being a competitive or replacing the value of pain programs in terms of what they offer, because as beautifully articulated by Kelly and Frith, the value of the social and the peer group and that group-based learning environment is really important for the pain programs. But really just trying to look at offering more patient-centered ways that people can engage with treatment. So having the VR program as one option, as one that could be delivered in that rural way as a 6-session intervention, but also then the more intensive pain management programs, which require a little bit more time intensity and clinician input. There's been some great studies done by Beth Darnell in the States where they have compared a VR pain coping program against a VR sham, where they did the same duration of VR time, and the results for the pain-specific coping VR intervention was superior, and also against an audio-based pain-specific coping program. So there they were looking at the actual impact that VR as a medium might have greater results in that way. And yes, we did compare the results between the waitlist control and the 3 groups. So we did see that the VR intervention had higher outcomes. Our primary outcome measure was understanding of pain, where we used the COPI. So we did see improvements in both the VR intervention and the book-based intervention, which was really promising to see that changes in pain understanding can occur. But when we're looking at some of the secondary outcome measures in terms of pain self-efficacy, fear of movement, catastrophizing, that's where we saw the VR intervention had their effects on those outcomes. We're still mid-data analysis specifically with those outcomes and that RCT, and I can't wait for it to be all completed and published for us to share more broadly.
And there's one more question for you there, Hannah, about the setup costs of a VR program.
Yeah, great question. For us in particular, or I suppose for anyone looking at using VR in rehab, I suppose there's 2 sets of costs to look at. Is the cost of the devices themselves are quite low cost. So they're now accessible at JB Hi-Fi. The Quest 3 F is around $500. So, and that can be used for multiple patients. Obviously, it's like a reusable device, so the headset cost is low. Whatever software you're looking at, that would be the thing to look at for software licensing costs, and it's still a evolving space in terms of how to set that up. So for us, the path forward has been to access research grant funding to start to do some of this work, but I then think at a broader level they'll be looking at how it can become a sustainable part of healthcare system as usual.
All right, great. So I think, we've got a few things from the session today. Go and look at the go and look at the Hopkins Centre pain resources, the Pain Week resources from last week. The link is in the chat, and we also put up the QR code earlier on. I might actually share my screen again with that QR code, so that if anyone didn't get it earlier on, they can get it. That's the link to the resources. I think it's really exciting that the VR program is happening throughout all adult public pain centres in Queensland, and is potentially going to happen in the Children's Hospital as well. So I think that's really great, and it'll be good to see the results of that coming out in probably 6 to maybe 12 months, I would say. In terms of insights into the interdisciplinary pain management programs, it's been really eye-opening. I don't know if it's been eye-opening for me. It's been really touching. It's there's been it's sort of something that I think I knew about pain, that it's a very human experience. This is not just about it's not just about anxiety. It's not just about things being ouchy. It's about who I am as a person living with chronic pain, and who I've lost as a person now that I live with chronic pain. So there's a lot. It impacts on every area of your life. And one of the quotes from a recent study looking at things that people have learned about pain from pain management programs is, when it comes to pain, everything matters. So it's really true, and it's being borne out by this study as well. So I'd like to thank everybody for attending, and we are now at about 2 minutes before cutoff. So I'll wrap up the session here, and thank our presenters once again for donating their time and preparation to this wonderful Hopkins Hour. And I encourage you all to go and have a look at those pain link resources. We put a bit of effort into gathering them. So all the best to everyone, and we'll see you at the next Hopkins Hour.